Okay, wonderful. Well, why wouldn't I start a presentation now? Right, so the other thing as well, I already mentioned to some of you that I sacrificed a couple of topics just because I thought it's just too much on a sunny day and I don't want to overrun. So we'll try to make it within the time limit we have. I'm going to be talking about some general principles, then pain and anxiety, patient evaluation, medical history, tooth extraction, including wisdom tooth, and flap design and suture. And just sort of to introduce to the oral surgery, it's the branch of dentistry that deals with conditions that requiring surgical intervention, or basically pathologies that within the jaws and mouth structures that require surgical intervention. And as any principles that probably the most important to mention, aseptic and antiseptic, basically just to prevent germs into the surgical site. And all those tools can help, like hand washing, hand sanitizing, and autoclaving as well. And some principles are listed here as well. That's the barriers that we have. So we protect the wound. We have sterile gloves, sometimes sterile gowns, sterile masks and drapes, and all the protective wrapping for sterile instruments and stuff. And you will be, if you are second year, you will be shown how to open them, what's the sequence, how to prepare instruments, but that's very important as well. Logistics is quite important in oral surgery. Okie dokes. And so SPP, I mean, now it's such a massive controversy in COVID time where we have aerosol generating procedures, and unfortunately, oral surgery is not outside of that remit as well. We have aerosol generating procedures as well, and PPE will probably change for some time, but those are basic PPEs you could have for a single tooth extraction, for example. But then when you greet patient in oral surgery department, no matter where you are, if you are a general dental practitioner or you're a student or you are a resident in a hospital, there are certain elements that you always follow. When you meet the patient, you apply certain concept that you will probably pick. My favorite is ICE, which is ideas, concerns, expectations. So I just look at the patient, I engage in conversation, and I try to find out what patient would like from me today, what the expectations, what's the main concern and the secondary concerns. And that all helps in planning proper management plan. In the secondary care, you're going to be a little bit spoiled because you will have a referral letter. So you will have a little information about patient. But if it's a primary care and you've never seen the patient before, then you need to investigate and use all the tools that are available to you. Now, the consent form in oral surgery is very important. I mean, it's important everywhere, but there are cases of the wrong tooth extractions, especially for orthodontic reasons. So it's a legal requirement from GDC. And you need to consider, I mean, I don't see that often people consider preoperative analgesics like paracetamol an hour before the procedure, which actually really helps for some patients. And there's some preoperative tests you need to consider as well. We will go into medical history a little bit, but not too much. And if you're planning to do treatment under some sort of a conscious sedation or general anesthetic, there will be either other people involved in planning, like a general nurse, anesthetist, etc.
Dr. Kushnerev, are you meant to be showing the slides now? Because we're still seeing the graph.
Oh, really?
Yeah.
I was meant to be, yeah.
No, sorry, we didn't want to interrupt, but yeah, we just thought.
I just noticed, yeah.
Sorry about that, everyone. We're still looking at what year everyone's in.
Gosh, we got it. Really listening patiently there, weren't you?
Yeah, you were on a roll and we didn't want to stop you, but sorry about that.
So I mean, okay, well, we're gone through that. So that's the preoperative management I was talking about just now, where you greet patient in a clinic, and the thing that I like to use called ICE, where I basically find out what patient's ideas, concerns, and expectations are. It actually helps, even if it's not oral surgery necessarily, and then basically what I've been personally using. But if we just move on to a sensible approach on clinic, that you need to make sure you check your notes, you checked all the x-rays and investigations. And then again, it depends on which school you are and how you do all the safeties. In Manchester, we have whiteboard where we put patients' details and the procedure just to make sure that everybody on the same page. You need to check medical history. The consent is a legal requirement from GDC, and then you do WHO check as well. Now, we call it correct site surgery. Some dental school call it differently. Again, if you just go on a WHO check surgical checklist on the website, you can see what I'm talking about. So only then you can commence local anesthetic and the actual procedure. And I'll be showing you today a couple of procedures that have been done. It will be a wisdom tooth extraction. And then you do write up. So writing up of notes is important, and all the paperwork you will be facing is important. I'm pretty sure throughout year 2 to year 5, you're aware of the documentations, but the consent is, I mean, we can't really stop reinforcing that message that without the consent, you can't treat the patient. So, and you need to make sure it's very carefully structured and you've done it before, or you have observed that before, where you mention all the possible complications like bleeding, pain, swelling, infection. And for some procedures, it will be nerve injury or oral antrum communication, which is the sinus breach, etc. And that's how our consent form looks in Manchester. It basically have all necessary information, patient's data, the procedure, responsible consultant, what's the benefits of the procedure. If we're talking about extraction of the tooth, it will be remove pain and infection, and some risks such as pain, bleeding, swelling, bruising, and infection. Those are standard one. And you need to sign it, and you need to date it, and you need to put your job title. If one of those is not there, it's not completed consent. So you need to make sure that you have it all done. Correct site surgery, again, very important. It's a key area of clinical governance. And if you're not familiar with clinical governance, it's those barriers basically that we put in healthcare system just to make sure that everything goes well. With teeth extraction, wrong tooth extraction, I haven't heard one for a while. However, there were recently a wrong kidney extraction or the wrong amputation somewhere in UK. So you need to just make sure that the correct site surgery helps to prevent these things that you would expect not to happen, but as a human factor, it all happens, unfortunately. And it needs to be done prior the procedure starts. That's how it looks again in our department. So you have patient information, the procedure, and that you checked all the boxes, that you check the patient identity, and everything is up to date. And I mean, Royal College of Surgeons gave a guideline how to fill in the clinical notes. So I would pay particular attention to that when you're going to be doing your clinical notes. It's either on paper or it's electronic. You need to make sure that each point is addressed, including make sure there is a date and there is operator and assistant, and if a student or who is a tutor, etc. I don't think so for local anesthetic. Batch number is necessary anymore, but expiry date definitely has to be highlighted, and all those things, how the procedure went, if there were any complications, what's the closure, if you prescribe antibiotics or not, and then signed and dated. And postoperatively, clear sharps away. In oral surgery, we have a lot of sharps, starting from blades to local anesthetic to Luxator, which is a sharp instrument. And it's actually your responsibility, the person who operated, to ensure that you that you basically cleared yourself or ask somebody to help you with that. And that takes the priority. Now let's talk about local anesthetic. Local anesthetic is a type of intraoperative pain management, and they have different duration and efficacy. And obviously, mostly we use Lidocaine, but there are others on the market as well that you can use. There are two main groups, which is ester and amide, and then basically one of them shorter duration than the others and broken down in the liver, but the other ones are stable, broken down in the plasma. So for example, Lidocaine would work longer, it broken down in the liver, whilst Novocaine, which is quite old-fashioned local anesthetic. It's broken down in plasma, so it doesn't cause toxic effect on the liver, but it's sort of shorter duration. And that's how local anesthetic works. It basically blocks sodium channels, which basically means there's no action potential, no impulse, no pain. However, all other sensations that stay the same, such as mechanical, thermal. So you need to let patient know, because they will have certain expectations. If you numbing the area, they will expect that they wouldn't even feel a touch. So it might be a little bit confusing for them. There are two types of needles that we have for syringes that we use, blue or yellow. They're short or long, basically, but depends if you use metal syringe or if you use some fancy devices with vibration or jet injection, then they will be obviously different and will have different needles as well. Before you do local anesthetic on a patient, you need to check the cartridge. Now, those are the cartridges, and very important to have it checked before you inject. Not only expiry date, but it's all nice and clear without any cracks, leakages, etc. Anything cloudy inside. Although it has all the preservatives inside to prevent that, sometimes things happen, so you need to check that definitely before. Some people say bubbles as well. You need to make sure there are no bubbles, but quite a lot of them have bubbles anyway. And local anesthetic either come plain or with adrenaline or Felypressin. Now, adrenaline is hormone that has a very important function, but it also narrows peripheral system vessels. So it basically constrict vessels, and it helps for anesthetic to stay longer. However, obviously it affects everything else. So sometimes one may want to use Felypressin if you want to avoid any other effects of adrenaline. For example, adrenaline would be contraindicated for patients with angina and hypertension, whilst Felypressin, or maybe even plain with no any adjunct to it, they might be even better suited. But Felypressin is contraindicated in late pregnancy because it might cause premature labor. Couple of local anesthetic here that are available in the market. I'm just gonna go through quickly that. There's Lidocaine, pretty sure you're familiar already, and maximum 7 milligrams per kilogram. We all always struggle how to calculate, but it's about 7 cartridges per average adult person, shall I say. Articaine, another very good local anesthetic, slightly stronger than Lidocaine, but contraindicated for nerve blocks. So you can't do, you cannot do ID block with the Articaine, but it's very good for a better pain control, to be honest. Sometimes I combine Articaine and Lidocaine. If I'm doing wisdom tooth extraction, I do Lidocaine for inferior alveolar block and Articaine just as an infiltration, which I'll show you later. Citinest, very good with no adrenaline. If you feel that you can't use adrenaline in this particular patient. Bupivacaine, Mepivacaine or Vivocaine, they used for prolonged effect. This anesthetic works for about 8 hours. So it's very good in pediatric cases where you want local anesthetic to work a long period of time to cause less distress. And those are some of the complications of the local anesthetic. I haven't witnessed all of them myself, but nerve damage is very rare, and it can happen with Lidocaine as well. I mean, all local anesthetic are neurotoxic. We had patients who had nerve damage after local anesthetic injection with Lidocaine, and it was infiltration, and they had a region of numbness. So is it worth, because of that rare case, just to say that you might have numbness after the procedure? I mean, it's not universally concluded, but just something to bear in mind to find an explanation if that happens. Some paralysis I've seen before. We're all individual and we all have different craniofacial peripheral nerve systems running across the face. So sometimes you inject local anesthetic in facial nerve because you didn't expect that it's a bit lower, and then you end up seeing that half of the patient's face doesn't move, or they can't close their eye. They can also go a little bit pale on one side of the face or sweaty. So something not to be scared of, but just sort of be in control of the situation. Trismus, if you inject in the muscle, you will have trismus. You might do intravascular injection and patient might start experiencing palpitations. So you need to be careful with that. And some systemic conditions, I mean, allergic reaction is very rare, but there is no shame to check. I always trust patients. And if they said they had problem with local anesthetic before, I just send them, if they don't mind wait list, send them for allergy test for once and forever, rule out any true allergy to the local anesthetic. Infections, again, super rare, not going to go there. Toxicity, I mean, just to make sure you put the right amount and you use proper techniques. So if you do inject in a vessel, you would know that, so you wouldn't continue. And some drugs interactions as well, mostly with antihypertensive, diuretics. You need to be careful. Those that basically can cause change in blood pressure. Now, if you feel your patient a little bit anxious, or I mean, it's a good habit to employ it for every single patient, really, to use topical anesthetic, unless they have, for example, methemoglobinemia, which can cause some side effects. It can cause some allergies as well, but it basically reduces discomfort, and sometimes it's actually reduces discomfort dramatically where the patient wouldn't feel an injection. I feel it's great. I would prefer gel over any other, like spray or ointment. Local anesthetic techniques, infiltration. Now you have some pictures here. Infiltration basically is where you infiltrate the surrounding tissue. You either go in a sulcus, stretching slightly the cheek or the lip, or if it's on a palate, you just go into the projection of the root. And you really need to know anatomy of the roots on the palate. So some anatomy books or anatomy apps can really help you to know where actually apex is, just to make sure that you anesthetize the tooth that you're interested in and it's effective. You can use short needle for that as well. I think they used long needle just to take a good picture for this. Now, nerve blocks, a slightly different thing. Obviously, if you work in a group of teeth or you do some invasive procedures, for example, an extraction of several teeth where innovation comes from different branches, then you might need to consider nerve blocks as well. I quite like greater palatin nerve block, just after the border of the palate, in the projection of apex. Again, I do always let my patients know that they might start feeling that their throat getting slightly swollen, or they might experience difficulty breathing, which is not associated with breathing, just sensation of something swollen. So, I mean, prepared patient is the best which you can get if something goes wrong. Inferior orbital, I mean, I don't remember when last time I used it, but sometimes you use it for extensive procedures as well. Incisal block, very painful. So I would probably substitute it through the like transpapillar buccally rather than shooting straight away, because it will be very painful. You wouldn't sort of avoid that, I'm afraid. And mental block, I mean, mental block is exactly the same picture as for infiltration in the same area. I mean, if you read a good book about basics, they will say, yeah, mental block, you go in the area between premolars, you hit the bone, you go a little bit backwards and you inject. I mean, I would never recommend hit the bone, because you may as well hit the nerve. I'd rather sort of do that as in infiltration anesthetic and let the nature and the gravity work for you. It will definitely anesthetize, especially you can use in this area 1 or 2 cartridge if you're not sort of, but I wouldn't go too deep mental nerve, because it's very common complication of damaging mental nerve. And my favorite and most controversial is ID block. Now I try to get the best pictures for my personal understanding of how it works. There's so many books specifically for ID blocks, so many YouTube videos. I do invite you to check them. But basically, you palpate the coronoid process. That's where the index finger of the person at the moment. And then you divide the distance between the lower occlusion and upper occlusion in halves, and go maybe half a centimeter or in the middle of the, you see there is a pterygomandibular raphe there. And then you just go into that spot. I mean, if patient doesn't have teeth, it's a little bit complex, and it's better in this case to go a little bit higher, so you can sort of get sort of a better anesthetic without seeking complications, and you wouldn't go any lower than that point, because otherwise you can actually inject into the nerve. It's difficult, but you can. And I mean you can start as shown on the picture. You can start from the canine, go penetrate the mucosa. Again, I wouldn't bump into the bone. A lot of textbooks say that you hit the bone, then you go a little bit back, you turn around. I mean, if you hit the bone, you hit periosteum. Periosteum has innervation, so the patient will feel a prick in there. So I wouldn't do that. But you can inject a little bit into mucosa and then turn around onto the incisors, and then carry on with your syringe, injecting anesthetic as you go. So you separate all the tissues away from the needle by injecting the anesthetic and going about 2/3 of the needle, and that should work. I would use normally 2/3 of the cartridge, or maybe the full cartridge. But one all that done, you finish with the patient. I mean, adequate postoperative pain management is paramount importance. And I mean, again, everybody overlook, but a good advice on what to buy over the counter, what to take, how much. You can't really assume that patient know all of that. So you need to let them know and reassure that they know if they know. Okay. And there are a few things, quite basic: paracetamol, non-steroid, opioids. Obviously, this is for hospital patients, for extensive procedure that you've done. But they are over the counter, such as paracetamol. Here we are, 55p. One of the most common medication, probably one of the most safest after the vaccines, I don't know, and basically works on the brain COX receptors, inhibits them, so it doesn't really have side effects as such, and it's basically increases pain threshold. That's why I think paracetamol actually good to have 1 hour before the procedure as well, because it increases pain threshold. And it's not like you want to save on local anesthetic, it's just patient will feel a bit more comfortable, I feel. Non-steroids, ibuprofen and aspirin, again, over the counter. We are more into ibuprofen. In United States, they quite like aspirin, but anyway, so 40p, last time I checked, over-the-counter medication. It's probably pain relief better than paracetamol. However, it's COX-1 and 2 inhibitor, which basically throughout the body, for example, in stomach and in kidneys. So you need to be really aware of that you can't give it to a patient with gastrointestinal problems unless you give them specific direct instructions. Take it after plenty of food and water, etc. Patients with renal perfusion problems or patients with cardiovascular situation, if they're already on aspirin, then you need to consider not to prescribe any more ibuprofen, not to add to it. But they're working at the moment on a new non-steroid that doesn't have that, but it still hasn't been done. So we'll wait for now. And I mean, as I mentioned before, here we go, paracetamol versus ibuprofen. Both are good. The only thing that paracetamol can cause sometimes fatal toxicity if patients really overdo it. Again, this is the importance of letting patients know how much you take. You can't assume that everybody know how to take paracetamol. And ibuprofen, also good as well, but you just need to know your medical history for sure, with kidney, stomach, and heart in particular, for bleeding disorders, etc., because it's important for that. But you can combine paracetamol and ibuprofen, and it especially works well for extractions that were slightly longer in time or maybe slightly more difficult. Opioids. Now, we are doing really bad with opioids in terms of a lot of patients in UK take moderate to severe pain relief opioids, and they kind of sort of hooked, I'm afraid. Worst case scenario in the United States. In dentistry, we don't really contribute much to that, but we do prescribe sometimes codeine, and actually codeine wouldn't touch much the extraction pain, really. So you need to really give it in certain circumstances. Maybe there was full mouth clearance or something, but sort of codeine you would prescribe as cocodamol probably, which has paracetamol. I mean, that will probably work better. And tramadol and morphine is something that I wouldn't talk about, because that's for exceptional circumstances we wouldn't usually prescribe. And this is in the hospital. So just a little summary table for you, that we still rely on paracetamol and ibuprofen, over the counter, very easy to access for everybody, very easy instructions, and not too bad in terms of their complications and contraindications. So quite straightforward. And I mean, codeine, also cocodamol, is the second, I guess, choice for something a bit stronger. Now I'm going to be talking about anxiety. It's a serious matter, actually, dental anxiety. It prohibits some patients seeking dental care, and they end up in their early 20s seeing us as oral surgeons for full dental clearance. And I mean, we're all heartbroken because of that, but in UK, it's about 11% patients do have dental anxiety, and they actually have it for real, that prevents them to seek care. Some countries are varies from 4 to 21%. And 5% of patients at some point in their life will need a sedation. Now, again, it's important to know, because it's not only related to anxiety. Sometimes the procedure is complex, and you need to be nice to patients. You need to offer them sedation when appropriate. So obviously, for sedation, there's some indications. I'm going to briefly mention sedation, not to spend too much time on that. But basically, if somebody clearly anxious, if the procedure is long, you have 4 wisdom teeth extraction, or you have a very complex horizontally impacted wisdom tooth, you don't want to do it without any adjunct, really. But unless patient really sort of, it's patient's wishes, again, you need to consider. Some medical conditions you need to consider, like epilepsy, for example, and special care dentistry as well, of course. And that sort of outline of the management. If patient even anxious, I would try a couple of behavior management techniques, and then go basically upwards from inhalation to intravenous to general anesthetic. I personally would never jump to general anesthetic straight away, unless it's a procedure dictated general anesthetic, when I have zygomatic implants or full mouth rehabilitation implants, and you want to do it all in one go. That's for sure general anesthetic, even if patient is very brave about all of that. But if a small procedure, single implant or single tooth extraction, and patient can't even let you examine them, then you need to start thinking about beyond behavioral management, something like intravenous sedation, and see if that works. Some behavioral management techniques here. Again, not going to stop here too much, because you have it all available in guidelines. IOSN, worth mentioning, indication of sedation need, how to check if patient needs sedation. So it's basically an anxiety score combined with medical history and treatment complexity. So patient fill in an anxiety score, how anxious they are, and then a practitioner fills in medical history and treatment complexity. And I highlighted here, if patient has gag reflex, I would consider maybe they do need sedation. Depends on the procedure again, but sometimes they can have epilepsy, and it will definitely make me feel like I need to talk to a physician about this, and maybe I will need sedation just to make sure I don't provoke epilepsy in the chair if we have it done under local anesthetic. And treatment complexity, obviously, as I mentioned before. That's the article from BDJ. Recommend to get yourself familiar. And some different modalities: inhalation, intravenous, general anesthetic, oral, and intramuscular. We do use oral premedication as diazepam or temazepam, and it works really well. The onset is quite lengthy though, so you need to consider that. You need to ask to come an hour before. And it's a poor control as well. You can't really control how much you sedate patient. Intramuscular a little bit better, but not used as such. But intravenous, I guess you have the best control if patient needs sedation. Right, so where are we on time here? I'm just gonna have a look. Right, so I'm just gonna put the video on. That's basically donning in operation theater, and then we'll start talking about proper oral surgery after that. Right, so that's just sort of to get you into environment. Hopefully it was interesting for who never been in theater. So it's basically how you prepare yourself before surgery in theaters. And then let's start with a oral surgery history taking, and then I'm gonna take you through some instruments and some procedures that you'll be doing. Now, obviously, history taking starts with personal details, and then you ask about the complaint, and then the medical history is important. Patient might not necessarily be clear of what you need to know, so they might not necessarily know that you need to know a medication that they take. So you need to sort of get that sort of clear that it's your responsibility to ask patients medical history, including any problems with heart they had. I normally do system by system. So you start with cardiovascular, then you can go endocrine system, gastrointestinal system, central nervous system. And then you ask about any medications they take. So that will give you an idea as well if they have any conditions you need to be aware of. Social and family history is important, including alcohol, smoking. And if you in pediatric clinic, then who is that came with them? Is that their relative? Etc. So, and any potential conditions that might be in a family as well. So if you're year 2, it's great if you listen to that as well. So ASA great if you want to impress your tutor. Every time you assess patient, you put ASA great. I mean, that's not entirely gold standard, but it will be a good indication for patients' health in general. ASA1 is healthy patient, ASA2 with a mild condition that is well controlled, and that's also including smoking actually. All of which can be treated in primary care, but if patient is ASA3, they would probably need referral to secondary care in a hospital. And before you treat them, you will need to stabilize that. So they actually can come back to you if you talk to their GP, for example, if they have uncontrolled high blood pressure. And on the left, there's some sort of pre-procedural factors that can influence contribute to the medical history as well. Some of type of the procedures and for example, any prolonged procedures can exaggerate some conditions. So sometimes it's good to split procedures into two or do it under sedation, etc. Exodontia. Now, exodontia is extraction, and the goal is safe, efficient, painless tooth removal. And there's some instruments for you that I'm sure you're familiar with, but I'm gonna go through and how to use them. Now that's the instrument tray that you've seen before, and you can see there is local anesthetic here with a blade, with some mosquitoes. Those are mouth props that you can sort of ask patient if they don't want to keep their mouth open. You can put mouth props so they can just rest on it, or if patient is under general anesthetic. There's some elevators here, there's some cheek retractor, and some suturing kit as well with suction, gauze, and that's for needles, basically safety for needles when you dispose needles and blades. There's some forceps as well, and let's go through some instrument. Now, probably the most popular elevator is couplant. Now you can see it's sharp corners, very sharp. However, otherwise it's blunt, and it has a very strong elevating point. It's used with the gauge. It's broad and flatter than Luxator. It has few sizes, and you use it in rotational movements. And when you use it in rotational movements, you really go clockwise or anti-clockwise. You don't sort of twist it around multiple times, because you just destroy the gauge, the application point. And basically you can cause the pressure to dilate alveolar bone, which will obviously help the extraction. And you use it perpendicular. And that's how you use couplant. So that's the tooth you extract, and then basically you rotate it, you rotate it in this case clockwise, so you extract the tooth number 7. Okay, that's Luxator. That's a very sharp instrument, and some schools actually don't introduce it straight away. They introduce it later on. I know lots of clinicians don't like them. I would say that this is my favorite instrument if you use it correctly. You need to use it gently, and you need to really have a good tactile feedback of how you use it, because it can be dangerous if you use too much pressure and don't have really good feedback. It's used along the axis of the tooth, okay, so thus it's parallel to the tooth. You push it apically, and again, the pressure should be very controlled. It can be in 2 sizes, 3 and 5 millimeters, straight or curved, and it's very sharp. So make sure you have your rest finger and the supporting alveolus where appropriate, just to make sure you don't traumatize patient. And that's how it's used. You basically insert it into periodontal ligament, you rip the periodontal ligament apart, and that basically luxates the tooth. And then after that, you have enough space to put couplant in here and to finish off the extraction, okay? Just one of the techniques. And that's how you use Luxator. So this Luxator is not straight, it's slightly angled. And then we're extracting, I see it probably second premolar from here. So you just go between the bone and the tooth and luxate the tooth. And that's the lower one. So that's the lower right 6. Now a little bit more fancier instruments, cryers, right? Very sharp and normally designed for roots. If you broke the crown and you have a root to extract, you can use cryers. Same for Warwick James as well. They can be angled or straight Warwick James, and also good for roots. Sometimes you can actually extract the upper wisdom tooth easily with this. And they're used in rotational movements, really. So those are the only one that you can keep rotating. I'm a bit dyslexic in terms of which you need to use. So I just take one, it's always wrong. So I need to change it, but it's actually site specific and application specific. Cutting side is blunt, so it's not sharp. However, it still has a quite substantial force that you can apply. So you need to be careful with that. And they're good for upper third molars and retained roots. You can remove intraseptal bone as well with cryers, but that's kind of sort of advanced once you feel comfortable about that. Forceps, here we go. Just gonna go through quickly because I'm pretty sure you can do it all yourself. I mean, I don't know what notation is in your department, but we have that notation. However, I don't remember numbers, so I keep calling them by basically what they for rather than a number. There are many types. There are tooth specific, anatomy specific, jaw specific, and operator specific as well. Some operators are left-handed. Some instruments are actually universal, so they're for both. Okay, so that's important. And don't forget your tooth morphology. So tooth morphology will let you know which forceps is for which tooth. Now this is lower forceps. That's how they look. They're like a beak, okay? And that's the upper forceps. They slightly bent and basically go straight on your palm, okay? Upper premolar forceps, that's for premolars. Upper right molar, and you can see beak to cheek. So the beak over here will go in bifurcation between mesial distal buccal roots of the upper right molar. Okay, so once you sort of imagine the anatomy, it will be very easy for you to know which one you use for which side. So that's for upper right. And this obviously upper left, so that's the beak on the other cheek as well. And if you remember beak to cheek, you will be okay with that. Upper roots, narrow and slightly longer than usual to reach roots. Bayonets, those are for upper eights. They go really, really far in the mouth, so they're called bayonets. And upper roots as well, the cheeks are comes together, means they for roots. And the correct usage is that you support alveolus with finger and thumb. Primary movement is always apical, so you're not actually pulling out the tooth. You actually pressurize it apically until the periodontal ligament breaks down. And secondary movements usually buckle, but it depends on the tooth again. Single roots, you just rotate, and they normally go out. And the multiple root tooth, you can do a figure of 8, and that's how you enlarge alveolus, break down periodontal ligament, and the tooth will come out. Lower forceps, so they have beak, they're slightly easier than upper. So that's lower premolar, tooth and roots. Lower molar, eagle beaks, basically. So they have beaks on both cheeks because lower molars have only 2 roots. So the beaks go into bifurcation in there. And car horns, I mean, they're good. They're quite aggressive, but I like using them on the tooth with broken down crown. So you can then break the base of the rest of the crown with the cow horns and then perform the lower molar extraction as 2 single teeth extraction, okay? Sometimes tooth just pops out once you apply those forceps. Technique for the lower. You stand behind the patient to the right, you support alveolus, apical pressure, buccal movement, and then rotation movement on premolars as they are, well, to be honest, I had lower premolars, not single rooted, but majority of them are. And molars, you do figure of 8 again. And if left-handed, then opposite applies. I mean, I know it's difficult, and I hope your department has accommodated the need for left-handed instruments or just got universal instruments, but it's not everywhere the same, unfortunately. So you just apply the opposite. Here we go. That's the lower right side. That's how you extract the lower tooth. standing, so on the lower left side, however, you stand in front of the patient. You again support alveolus, apical pressure always, and movements are same as lower. So technique for upper, you stand up straight. Patient should be quite high actually. So patient's head is at your shoulders height. Arm straight with forceps. So your arm has to be straight. If you bend it, you will basically jeopardize biomechanics of the extraction. And you use your body weight, but very controllably. So don't actually like take several teeth altogether. So just make sure it's all controlled, but sort of in that manner that this gentleman shows us on the picture. Now, some teeth extraction would require you to raise a flap. Sometimes they are deep down, roots buried. Sometimes you have a wisdom tooth. And there are certain principles apply to design your flap. You need to outline the incision. So you need to make sure you're aware what incision you're going to be using. You can even use a sterile marker. So I don't feel there's anything wrong for inexperienced operator to outline the incision, check with more senior colleague, and then go ahead. Blade should be on the bone always, never be on the soft tissues only, because you can traumatize everything. The flap should have adequate blood supply, so the base of the flap should be broad. However, you still have to make good access. So if flap requires to be quite large, then it has to be large. And you need to think ahead, and you need to think, how are you gonna suture it back? So you need to make sure you know how you're gonna reapproximate that. So think ahead about suturing and practice suturing. I would recommend either buy set like on Amazon and practice on a chicken skin, or practice on orange. It will give you some confidence once you're going to be doing the same in clinical environment. And this is just to prevent all those problems that can occur with flaps. And that's basically some types that are highlighted. There's an envelope-like flap, where it's literally you just go around the teeth with a blade, and then you lift the flap with a Mitchell or with a periosteal elevator. This is a four-corner flap or three-sided flap. Now you see this flap has one side, second side, third side. So you can call it either three-sided flap or four-corner flap, because it has four corners over here. Now this is good for a bigger exposure. So you have a bigger area, you can access the root in the whole length comparing to this. And slightly less invasive, but similar to three-sided, is two-sided. So you have one and two. You can call it basically an envelope and a mesial relief, basically. So that's for some slightly smaller access, and you can put envelope here and relief here for aesthetic reasons. So you can sort of see, it depends on the situation, obviously. And here are some of the situation, for example, where you have a wisdom tooth in this particular area. That's how the flap will go. So it will be theoretically three-sided flap, okay? And then you lift it up. I'll show you in the next slide. Okay, everybody can see my presentation.
Yeah, we can.
Perfect. Just checking, just checking. So that's another flap, almost similar to this one as well. So it's three-sided flap for wisdom tooth, taking extra tooth as well here, okay? So it's just basically increasing the access. We're not taking this tooth. This is only for wisdom tooth that buried there, but we need to increase the access just to have clear access to the bone that we'll be drilling, for example. On a palate, you almost always use envelope-like flap. That's enough. That's for buried canine or supernumerary tooth. And for apicectomies, like over here, you would do a proper large, broad flap, which gives you a good exposure, because that's a primary importance, obviously. So you need to consider all those things. And obviously, after you perform an extraction, you need to achieve haemostasis. It naturally occurs. However, you might want to use pressure. You can just apply pressure with the gauze. You can use electric current, like a bipolar or monopolar, but that's quite advanced. I wouldn't necessarily require that for simple extraction of wisdom tooth. Suture is sometimes very good, especially if you did raise a flap, then that will be your hemostasis, okay? Some chemical reagents, you can squirt a little bit of local anesthetic on the area and let adrenaline work. You can use tranexamic acid, also stops the bleeding. Silver nitrate, very cautious to be used because it can burn surrounding tissues as well. So I wouldn't use it in first instance. And basically, to manage hemostasis, you really need to feel and think ahead. Think of your procedure, think about your patient, think about medical history, and you will anticipate of what type of hemostasis you're going to use. Is it going to be just natural one, or you might use something else? Wound closure. So when you want to close your flap, there are certain sutures you need to bear in mind. We normally use absorbable inside the mouth, and mostly they are braided. It's mostly Vicryl Rapide or regular Vicryl. They both will start be insufficient on a day 8 to 10, okay? And then they will completely resorb in about 30 to 50 days inside the tissue. So you don't need to take those stitches off unless you have to. So that's why we like to use them. However, if you work in a primary care or in a private practice, a lot of non-absorbable like Ethylone or Proline or any other suture have their use as well, because they cause less local infection and tissue irritation because they are synthetic, and you will remove them completely. You won't be waiting for them to resorb naturally. And that's the needle, so the pointy side and the suture side of the needle. And somewhere here, you will grab the needle with the needle holder. Needles have different pointy ends, and you really need to look for reverse cut. So that's your image on the suture material. You need reverse needle for mouth purely because you don't want to tear tissue. Because if you use, for example, a regular cut or pointy one, it would not penetrate the tissue properly. It would not slide through. And this one will just tear it apart because of the pressure you apply. So the best one is reverse cutting for mouth. And that's how you grab it. And that's simple interrupted. You start 90-degree perpendicular to the tissue, equal bite on both sides. You are basically rotation movement. You don't put pressure, just a rotation movement, and then surgical knot time. Now, I would recommend this atlas. I mean, it's a very old atlas, but it describes quite simply in steps how extractions are done, from the insertion of the instrument in the mouth to the apical pressure, etc. And I hope it helped. Here's my reference list with some hopefully useful things that I'm sure you're aware already. And if you have any questions, I'm more than happy to answer any remaining questions. And I'm stopped sharing video now, so I'm back full screen.
Talking about myself on mute. I think you've got most of the questions there as you're powering through. But oh, somebody's asking, can we see the references and links again, please?
Of course. Only for extra charge, though.
Get your money's worth.
Can you see it?
Yeah,
that's good.
Wonderbar. Nice SD step, resas, your main guideline, basically main points to go for. I mean, there are more than that, obviously, for like a best oral hygiene, Cochrane library, PubMed, dental updates. I'm pretty sure your school has a subscription. Grab a journal and have a read. Just sort of don't limit yourself with guidelines and recommendations. Go beyond and above and try to do your little research if you're interested. So yeah, what's happening in the chat? Under what circumstances would you use tranexamic acid? I use tranexamic acid if my patient has bleeding that does not stop, I use tranexamic acid for all patients with some bleeding disorder. It's normally prescribed by hematology department as a tablet, actually, in advance. You can use it in ampulla. So you can use it, you can just pour it on the gauze and just sort of ask patient to bite on the gauze where it bleeds from. And tranexamic acid can be also used as a mouthwash for patients, for example, after full dental clearance. Those are circumstances basically you need to envisage. If patient takes aspirin, I would not necessarily consider them high risk of bleeding, to be honest, but it might be a sign that you might need something more than just natural hemostasis. But for example, patients taking novel anticoagulant medications where you not necessarily have to stop them, then you might end up actually have a little bit prolonged bleeding or a little bit more than normal. So again, you can use tranexamic acid. How do you prevent an oral antrum communication from happening? Well, first of all, common sense. Secondly, making sure you know that oral antrum communication is a possibility, and you just being honest with yourself, with your colleague, and with your patient. Is it going to happen or not? Can it happen or not? You discuss it with patient, and then you extract the tooth. How you prevent this from happening? Atraumatic, gentle extraction. And then it happens, I normally treat it, you know, when things happen, it meant to happen. You just need to be, you just need to then use common sense. If you're unsure, ask a colleague what to do. If it's small, then you can put sort of Surgicel to achieve hemostasis and leave it, and see patient again in a week or two to see if it closed. If it's huge oral antrum communication, so you extract it, I don't know, upper left 6, and it's a massive, went with the whole septum and a bit of sinus, then you would probably try to repair it now and then, and you would probably need to ask a senior colleague to help. I would expect that all teeth that high risk of substantial oral antrum communication referred to the hospital as well. So just know your limitation. And I mean, there is no way you can 100% prevent complications, but the best measure for that is just to know they may happen, and you know exactly what could happen in this particular situation. What would using Articaine do to the patient if used in a nerve block? Does it cause paresthesia? It's interesting how it's causing quite an interesting debate. Articaine is neurotoxic. It affects the nerve to the point that it basically, I don't know exact mechanism, but patient might never regain sensation related to that nerve zone of innervation. It might be significant, it might be not. I would say probably in majority of cases, it will go away in about 3 months, but there are cases, very small percentage, where after Articaine block, they haven't regained complete sensation for years, meaning they probably would never have that. There's been a gradual move from some clinicians avoiding ID block due to risk involved. How do you feel about avoiding ID blocks and trying to buccal and lingual infiltration instead? I mean, I know in London, in King's, if you're from there, the clinicians in London particularly try to avoid ID blocks just for that reason. But I mean, you can use Articaine for infiltration for the tooth that periodontally involved, and that would be fine. You can use periodontal ligament injections. You can use jet syringe, which forces the anesthetic into the bone. This helps you to avoid ID block. Not all departments have it. Not all patients would have periodontally involved tooth. Sometimes you just cannot avoid using it. You will have to block the nerve unless you have a spare, I don't know, maybe 20 minutes or half an hour until all the Articaine will settle within the lower jaw, because lower jaw is quite dense. That's why you need block, pretty much. If a flap becomes necrotized, is there any treatment? Yes. Yes. Again, flap I guess the best treatment for the future is just to recognize why it's become necrotic. So they either short base or tight suture, or it wasn't sutured properly, so it's got infected, or the design was not appropriate. So one of those can cause necrotic flap if we're talking about oral cavity at the moment. In this case, you have to just let it granulate. So the dead flap will never become alive. It will just shed off. And the bone, whenever it was covering, will have to granulate, and it will have to heal by secondary intention. So and basically the treatment is seeing patients every now and then, prescribe them proper mouthwash, and maybe some debridement if necessary, if the flap is necrotic already. Any more?
I think you've covered everything.
Nobody want to go outside. What is this?
Everyone's so interested in oral surgery this evening.
Hmm?
Everyone's just interested in oral surgery now. They're not arsed about the weather.
Yeah.
There we go. I think you've touched on everything. Yeah, we were all saying there, we really appreciated the fact you've gone through nice and slowly and built it up. And it's good revision, especially with us not being able to be in the hospital. It's nice to go step by step through things and refresh things. And no, I thought that was another question. But no, thanks very much, Dr. Kushnerev, for taking time out in your Thursday evening to come and speak to us and tell us all about.
Yeah, thank you so much for invite. I'm gonna stop sharing screen now, and hopefully you have lovely rest of the day, and looking forward to your weekend, which unfortunately not gonna be as lovely as today.